next, we're going to chat a little bit about our change to needle decompression, some of the thought process behind it. It really didn't change our guideline much as far as what's documented, but it's definitely going to change the procedure in which we go about placing these devices because it's quite different. With that said, North American Rescue makes this product, so we're going to utilize their slides that they put out publicly. This device is different, and there are some increased potential complications, and that's why it's worth us going through this in detail and talking about the difference in insertion and application of the device. And just as a reminder that this is not a device that we use on the pediatric patient, and that we only want to be using these devices for tension pneumothorax. Your suspicion could be high for there being a potential pneumothorax, but if it's not causing hemodynamic instability or imminent life threat or presenting with what we describe as the tension physiology, it's not something that we're forced to act on and address. But we have patients that we see in the ED all the time that we find pneumothoraces on, and we don't need to address them emergently with a needle decompression. Sometimes we'll place pigtail catheters. Sometimes we'll talk with our consulting docs to see if, such as our pulmonary docs or our trauma docs or interventional radiology or cardiothoracic surgery, to discuss the best way to manage a pneumothoraces in general. Don't run in there with a needle if they're stable. So once again, this is for a true tension pneumothorax, hemodynamic instability, and concern for compromise and life threat. In general, just a summary slide, we're going to go through identifying the components of the Sphere catheter itself, hopefully highlighting some of the differences there. We've taken out some of the indications, contraindications, as that's something that we cover within the guideline, and we have been covering throughout your training and competencies, so not truly unique here in that sense. We will utilize kind of some of the landmarks that they talk about because it's an excellent review, and also how to basically successfully place the device and avoid some of the complications that we might see with this device, especially if it's improperly placed. This is a diagram of the Sphere. In many ways, the Sphere catheter is different than our standard catheter. For the first point, it does have these fenestrations, so it's got these little holes. It's not just a hole at the tip, but there's also kind of fenestrations throughout the first 3 to 4 centimeters of the device, which you see in these indicator bars. So that's one difference compared to the standard IV catheters that we've used for decompression in the past. In addition, there's a Luer lock here, so you actually will need to spin the catheter off of the underlying needle. Speaking of the needle, there's a modified tip. It's a little bit sharper. It's more enhanced for piercing skin at the angle that you're going to be going at, so it tends to have less potential failure rate compared to IV catheter placement. And with that said, it is a 10 gauge needle, so it's a little bit different than what we're currently carrying with our 12 and 14 gauge IV catheter supplements. And then in addition to that, at the end of this device, there is a one-way detachable valve that you'll take off and put on. So that's another feature to this device that we don't have with our IV catheter-based decompression devices. And lastly, it is longer. It's 3 3/4 inch length instead of 3 or 3 1/4 inch length, as most standard needle decompressions are. So moving onward, this is the packaging that's going to come in. So initially comes in this protective plastic case. In picture 1, you can see that it's still sterile. That's the sterile packaging over the break point in the case that it comes in. Over here, you can see that you kind of twist and break the seal. So that would be a seal broken, meaning no longer per se sterile if found broken. And then we could see with the cap, the red cap coming off, which will be the cap you want to take off. That is the way it is loaded. The needle is down at the gray end, and the back end with the one-way valve is on the red end. So you want to pull off the red cap, leaving the needle in the gray cap so we don't stab ourselves. With that said, everything taken out, there's our 2 pieces of the case for it, as well as the actual catheter itself. And just showing some of the features of the device in more detail. It's a 1/4 spin lock, so it's only a 1/4 of a turn. That's what's holding it on with almost a Luer lock type device. So in order to thread that off, you have to turn it a 1/4 of the way. It's not on, multiple times or threaded multiple times. With that said, once the needle is removed, as we would anticipate, the catheter is flexible, as is our other catheters, but just to demonstrate the different functionalities. And then once again, here is on the needle end itself. So going back, you see the catheter comes off. This one-way valve actually stays with the needle as you take it off, and then you would need to remove the one-way valve from the needle itself, from the back of the needle, and you could place that onto the inserted catheter that is there. And as they're showing here, these blue arrows heading towards the catheter, that's where those fenestrated holes are, including at the tip. So you have a few different access points and hopefully less likely for things to clot off or get blocked off once it's placed correctly. And then this one-way valve that should be expelling air and not allowing for air to be entrained back into the pleural space. So once again, our indications, I think we all know these. These are, in general, what I just want to leave here is as a reminder that this is for tension pneumothorax. Oxygen saturation dropping, hypoxia, decreased breath sounds on the affected side, signs of tachypnea, respiratory distress, hemorrhagic shock, and hemodynamic instability in the setting, especially of traumatic injury or cardiac arrest, are all our indications to treat a tension pneumothorax or treat a pneumothorax that is concerning for a tension pneumothorax. And once again, the contraindications really not for pediatric patients would be the most important one, and not just for simple pneumothoraces or hemothoraces, as we've already discussed. And in general, the signs that we're looking for, just to review, would be improvement in respiratory distress, or with successful placement and relief of a tension pneumothorax would be a decrease in respiratory distress, or relief of said pressure or shortness of breath, an improvement in oxygen saturation, as well as improvement in vital signs. As far as our anatomy, we have two different approaches to the needle decompression. We have the anterior approach, and we also have the lateral approach. So we'll talk about the anterior approach first. We have in detail discussed this before regarding kind of specifically that while there's some preferences to a lateral approach, specifically there is decreased thickness to the skin, and there's some studies looking at this that suggest that there's increased success rates on the lateral chest, specifically the anterior axillary line. We know from our operational setting that sometimes all we have access to is the anterior approach. So it is worth knowing how to place the device in both locations, as it might be necessary to place them in the anterior location over the lateral portion. So once again, this is the midclavicular line, second intercostal space. So that's above the third rib, below the second rib in the midclavicular area. What I will say here is while they identify very accurately and probably with some measuring device on the skeleton-based model, what midclavicular is, I generally see things in more generalities. And if you're going to decide to not have. So sometimes what I realize is that when you're trying to assess perfectly midclavicular is not a reality in the scenario. And generally speaking, in those moments, I will tend to try to place the catheter slightly more lateral. Given the option between being a little bit medial and being a little bit lateral, I will tend to place it more laterally. So that being said, I do recognize that it's hard to sometimes always know exactly what midclavicular is. As far as identifying that spot, some tips and tricks here. You'll want to identify the sternal notch. Right next to that laterally is the sternoclavicular joint space that you can identify. And then moving over, you could also identify the acromioclavicular ligament, or the notch. And that is kind of the edges of your clavicle. As you see here, those are the two edges of the clavicle. And then you work to identify the middle of the clavicle. So once you identify the middle of the clavicle, once again, you might want to even move just slightly more laterally to ensure that you're not moving accidentally towards the medial part of that line. You will want to move down to the second intercostal space, once again, maintaining in the midclavicular location. And there's always the helpful tip of the angle of Louis, which is the inferior aspect of the manubrium in the center of the chest, or at the top of the sternum. And that allows you to quickly identify the second intercostal space. And you just want to move laterally to the area you've already identified as being midclavicular. So you can create a lateral line from that angle of Louis coming across down the second intercostal space to the point with your other hand that you had already identified as being midclavicular. So you want to go ahead and compress firmly to ensure identification of the third rib, with the second intercostal space being just above that. Definitely, if we want to cleanse this area, potentially mark it, or just maintain traction with our finger in that location is where we're going to go. You want to go ahead and set up. You've already verified your site. You know that you're in the right place, and you want to go ahead and, if given the ability to, you kind of frame it. And then the term that they're using there is kind of taking your index finger and your thumb and stretching the skin over that area and framing that this is the location that you're going to go. You can see in their right hand that they are holding it in such a way that they're keeping good control of the needle by using their pincer grasp, as well as kind of controlling the top. This will take a little bit of time, I think, for us to kind of adjust to and practice in sim, but in reality, getting in a position that you're controlling the needle and the trajectory that's going at. And what they're very much so trying to set up here with that red dotted line, as we've talked about before in invasive skills, is you're not going perpendicular to the bed or to the ground or to the patient's back. You're going perpendicular to the chest wall. And the thoracic cavity is not simply a square or a box, it is curved. So you might actually be coming in on this broached angle, as you can see in this diagram, but that is accurately and appropriately 90 degrees or perpendicular to the chest wall still, while it is not perpendicular to the floor. They're recommending that you come over the third rib itself, and once again, perpendicular to the chest wall in the midclavicular location. So with that said, they're showing here that once again, we went from kind of controlling the needle at the tip to changing to more of a penciled formation. And as you're going in, you will be coming down probably right on top of the rib. We don't need to stab the rib aggressively. We don't need to push on the rib very hard, but you do want to kind of come down on top of that rib at first with a plan to go over that rib and come over the cephalad orientation of that rib, coming over the top of the rib. With that said, one of the most important things that they're showing here that I don't think they fully describe in this initial picture was notice how they want our finger to be placed pretty far down on the catheter, near the 3rd or 4th centimeter-ish mark where that fenestrated hole is. And the idea here is that we don't want to bury this needle too deep in. We're not to hub this needle. So I do actually like this orientation, and I like the fact they're using their finger as almost a stop block to saying how far that they're willing to insert before you're going to reassess to see where you're at. So as you could kind of see here, once again, as they're coming down, they're maintaining traction at the skin. They've come down on top of the bone itself. They're not hubbing the needle or burying the needle in. And what they're going to do is slightly angle superiorly over the targeted rib, which is the 3rd rib in the anterior space. You're going to kind of slightly go above that rib, translate up above and into the pleural space. And once again, not hubbing the needle, but maintaining this finger here as a stop block as we push into the pleural space, as we do not want to go too deep. Specifically, the manufacturers say to insert no more than 3 centimeters into the pleural cavity. With that said, hopefully we'll hear a rush of air. You will, with that one-way device on, still get an auditory cue that you've entered the right space. And at that time, you want to go ahead and direct the catheter towards the middle of the clavicle in that cephalad orientation. So you have this slight upward angle that you've come up and over the rib that is angled now towards the cephalad region, and you're going to spin the clear portion off of the catheter. So you're going to unlock that through a quarter turn, and you can kind of release the spin lock. Everything should remain stationary still at this point. So the needle is not going any farther in. You're just simply twisting off the spin lock. And as you do that, you can go ahead and thread the catheter over the needle while maintaining the needle in its position. We're not to advance the needle any farther. We're simply sliding the catheter over the needle. And once again, in that slightly cephalad direction towards the head and the middle of the clavicle. You will want to go ahead and completely thread this catheter into the pleural space. Once again, the catheter, the needle is still staying anchored where it's at in location, not going any deeper. We don't want to get that sharp tip closer to any of the internal structures, but you are sliding the catheter all the way into the pleural space. At that point, you can remove the needle, take the needle, if it's still in its location, you can take the needle out, you maintain the catheter in your other hand, and you can go ahead and remove the one-way valve. Of course, securing the needle, this is quite a large sword, and we want to be sure that we properly secure that in a sharps container, and removing that one-way valve from the back of the needle itself, and you can go ahead and place that onto the catheter as directed. And then from there, they're just showing here the way the catheter works. Once again, it's not just pulling air from the tip, the distal tip of the catheter is actually pulling air from these fenestrations as well. So if the tip is touching something or blocked by some sort of tissue or blood clot, it's actually still going to have some functionality through these fenestrations. This is the way in which I kind of joke that it's like a mini chest tube, not only in size, but in character and having those fenestrations. Here's just an example of it, diagram of it in place. Once again, how it's going to pull air from that pleural space through different routes, and that it's using a one-way valve that's designed for this device, not putting a glove over it or some of the other things that we've done in the past. With that said, to kind of quickly now just review, similarly to as we discussed earlier, the anterior approach. This would be the lateral approach. Look at the axilla. I disagree with this diagram. The humerus should be brought up. Their elbow and hand and head should be brought up above their head, just like what we do for chest tube placement. I would still use that same technique, getting the arm out of the way and going ahead and identifying the fourth or fifth intercostal spaces. And once again, we're going to be working towards between the anterior axillary line and the mid axillary line is the safe zone that we want to be working in, just like we do for a chest tube placement. Either mark that area, have that area identified with, once you've identified it, you're maintaining tactile location of that with your hand. You're going to go ahead and clean that area as quickly as possible and prepare that site for insertion. With that said, you verified that you're in the fourth or fifth intercostal space once again, between the mid-axillary and anterior axillary line. You're going to go ahead and do that same kind of framing with your index finger or your middle finger and your thumb, using your index finger to identify your site insertion. You're going to go ahead and kind of go in with a stable needle. Once again, they're showing a little different technique here that we identified versus holding with the one-way valve tip. Here they're showing the pencil holding technique where you're trying to control the needle tip as it's going in. And once again, ensuring that you're not going to accidentally insert the device at too great of a depth. So you want to go ahead and insert this, identifying what it means to be perpendicular to the chest wall at this location. Might not necessarily mean that you're quote unquote parallel with the ground or parallel with the stretcher. It's supposed to be perpendicular to where you're inserting, which sometimes on the anterior axis, close to the anterior axillary line, might be with a little bit of a cadence or an angle to it. You want to be perpendicular to the chest. That's always what you want to orientate your insertion to. Once again, identifying here that we want to have good stability of the needle. This is not a needle that we just simply want to hub in there like from Pulp Fiction. We're going to go ahead and target for the rib itself. I'm not trying to stab the rib, but simply just making contact with it or coming down over it with a plan to go above it to avoid obviously injuring any of our vasculature or nerve bundles underneath of it. And as we come over the rib, we want to ensure that we're not going into the pleural space any more than 3 centimeters. And we're going to do that through close technique as far as not hubbing our needle and kind of keeping our landmarks with a hand stabilizing that needle at all times. As we see here, once again, just as a reminder of that picture, one way to stabilize could be with a finger down on the needle itself and or holding it with your other hand. Once we've kind of hopefully got that rush of air, we know we're in the right space. We have not gone too deep. We've angled it. We're going to drop it slightly and angle the needles to the cephalad region towards the head, up towards the axilla once we've gotten in the space. And at that time, you're going to kind of release the Luer lock with a quarter spin. And while keeping the needle stationary, you're going to advance the catheter into the pleural space. Keeping that needle stationary and advancing the catheter, just a few different pictures of that. You can see how they're doing that with a two-handed technique there, as well as anchoring their hand on the skin to ensure they're not pushing the needle in any farther. The left picture here, see how they're anchoring their hand on the skin, holding the needle, and with the other hand advancing the catheter into the pleural space without going any deeper. And here's the diagram portion of that. Once you've placed the catheter into the space, you could go ahead and then remove the needle carefully. Once again, this is now a potential sharps hazard and needs to be discarded appropriately. Before discarding it though, you want to go ahead and get that one-way valve off, take it off of your needle and place it onto the catheter so it has the one-way valve functionality and doesn't simply just become a open wound. So that's overall the placement of the spear catheter and how it's kind of different. In general, the actual documentation change that you'll see to the guideline is that all we did was add that instead of being a 3 1/4 inch catheter, that now we're allowing for a 3 3/4 inch catheter to be utilized. And that allows us from a guideline standpoint to utilize the spear catheter. But in reality, as I think we demonstrated here, it's much, much more than that. It's basically a mini-me chest tube. It has a very sharp tip, and that sharp tip can lead to certain lacerations of lung tissue if it is inserted too deeply, or even damage to other structures such as cardiac structures and or great vessels. So we want to be very cognizant when we're practicing and going through our competencies and invasive skills moving forward, that we're getting used to this device and getting used to using it under pressure and kind of the pressures of a scene call. So let's take a lot of time with practicing our technique with that and kind of going over some of these things in person, really emphasizing the importance of depth control and controlling the depth of the needle and getting used to that kind of Selvinger type technique where we slide the catheter over the needle without moving the needle any farther in, and then removing that needle safely without, once again, losing control of it. Just as a FYI, there's some anecdotal reports from New Hampshire from non-critical care transport crews and EMS agencies that have had some injuries to maybe lung tissue or other things using this device. So that's why we really want to be cognizant of this. It's a great device. It has increased diameter. It has functionalities that don't come with our IV catheters. And I think that we'll find great success with it, but we definitely need to train up to utilizing it in a safe manner. And that's all I got for guideline updates for needle decompression.